Okay, next one.
Okay, so I've been provided with a magnified view of the central thorax in the anterior projection. Okay, so I noticed that overlying one of the ribs adjacent to the hilum, there is a well-defined round opacity projecting over the left, within the left, over the left rib within the hilum. I'm not able to determine what.
Well picked up. Good job. That's what you're referring to, isn't it?
Yes, yes.
Yeah, excellent. Yeah, rest of the X-ray is fine.
Yeah. So
there are no previous radiographs.
Okay, so if there's no previous radiographs and I haven't, and this is the only finding in the X-ray, then I would like to correlate with the patient's symptoms. This looks a very this is a well-defined mass. I need to determine. I'm trying to determine if this is actually arising from the lung.
Patient has cough and hemoptysis.
Patient has cough and hemoptysis. Okay, so in that case, then we will have to treat this mass with a slightly high index of suspicion, and we will have to get a contrast-enhanced CT chest to evaluate what this lesion is. And with it, what we can see on these dedicated soft tissue and lung windows of the CT chest is that there's a well-defined mass within a bronchiole within the left upper lobe, and this is likely an endobronchial mass. There is no associated lung collapse with this mass. It's soft tissue density. If there's contrast sequences, then I'd like to evaluate whether this is enhancing. And I can't see any lymphadenopathy within the left hilum. So in my routine practice, I'll look at all the slices of post-contrast CT, but my top differential here is an endobronchial tumor, such as a carcinoma tumor.
Okay, very good. Yeah, that's perfect. So when I show this case, some of the candidates don't arrive at the endobronchial part of it, which you did correctly, which is very good. So it is endobronchial because number one, it is arising from the inside of the bronchus. And number two, if it was arising outside the bronchial wall, then it would it will collapse the bronchial wall, which is not happening here. The bronchial wall is still intact because it's arising inside the lumen of the bronchus, and then that's why it's not collapsing. If it was outside, it would collapse the lumen of the bronchus. So that's a diagnostic feature to determine that it's an endobronchial lesion growing from inside and growing out. Obviously, distal to it, the bronchus will be, all the bronchi and bronchioles will be obstructed, and there will be distal to it, distal collapse. But often in these cases, what will happen is the air will still get through in a valve-like mechanism. It will still allow air to pass. So that's why there's no distal collapse in this case. So it's an endobronchial lesion. Keep that in mind. Identifying endobronchial abnormalities. And one thing you could have mentioned is it's in comparison to the previous nodule, which was peripheral. This is central, isn't it?
Yep, yeah, central.
Yeah, that's one pulmonary hematomas tend to be more central, whereas carcinoids tend to be, pulmonary hematomas tend to be peripheral, whereas carcinoids tend to be central. So central, like 75% are central, and smaller percentage are peripheral. So there are two histological types. Typical carcinoid, which is well differentiated and less aggressive, and atypical, which are poorly differentiated and aggressive. These are just broad differentials, but I would look at other features rather than just enumerating in an exam setting. Rather than if you are given a solitary pulmonary nodule, just rather than enumerating the list of differentials, I would look at other features in the chest to give you clue to arrive at a diagnosis. For example, if you see calcification, think of granulomas or hematoma. If it's a solitary lesion without no other change in the lung, think of more like hematoma, carcinoid. Whereas if there are changes of postpulmonary TB, think of inflammatory condition, and so on and so forth. So endobronchial or pulmonary carcinoid, I wouldn't think of adenoma because it's just a broader, just think as carcinoid, hamartoma, and endobronchial metastasis. Three top differences of endobronchial nodule: carcinoid, hamartoma, metastasis. Okay, next one.
So I've been provided the lateral chest radiograph of an adult patient, and my most striking abnormality is that as we go down inferiorly along the thoracic vertebrae, there's increased round density projecting over the two contiguous thoracic vertebrae. So the inferior aspect of perhaps T9 and the superior aspect of T10, so I am suspicious that this is a pulmonary pathology. In addition, there is a wedge-shaped increased density lying posteriorly within the lung, and
that's correct. So you identified this opacity, and then this peripheral wedge-shaped opacity. That's good. And you would normally ask for a frontal radiograph, isn't it?
Frontal radiograph, yeah. So on the frontal radiograph, corroborating with the previous findings, I note that there is an increased density adjacent to the right hilum with increased hilar prominence. In addition, there's a triangular-shaped increased density within the right lower zone. There is a slight ill definition of the medial right hemidiaphragm, which is not clearly delineated, and the right hemidiaphragm slightly also elevated. The remainder of the lungs are clear and there's no bony abnormality. So my differential here is a right lung mass causing right lower lobe collapse.
That's correct, yeah.
Okay, so I've been provided with a CT dedicated.
I'll just explain this because this is something that you have said already. So there's a mass and there is some distal consolidation. That's it, yeah, okay.
So I've got a anterior chest radiograph of an adult patient, and the most striking abnormality is that there's a round density within the right lung at the medial aspect. Looking at this density more specifically, the right heart border is clearly seen through this density. So this is not an anterior mediastinal mass. And the right hilum, the inferior aspect of it, is also seen quite clearly through it. So I'm happy that this is not a middle mediastinal mass. So I've got a posterior mediastinal mass within the right lung. This has a wide differential.
I mean, this is simple. I mean, you did say that you did bring in mediastinum in here.
Yeah.
But it's not mediastinum, isn't it? It's outlined by air almost through and through, isn't it? It is projected over the mediastinum, that's correct. But it's outlined by air, isn't it? A structure that is arising, mediastinum is the space in between the two lungs. Yeah. It contains heart, it contains the blood vessels, it contains the pericardium covering the heart. At that level, it contains only heart. Thymus is a bit higher up here. A goiter will be somewhere here, trachea there. So that we'll go into that later when we are in the mediastinum chapter. But this nodule or mass, it's outlined by air mostly. You can see, except the innermost border, you can see most of it is outlined by air, which means that it's in the lungs, isn't it?
Yeah.
Do you get the perspective? So there is no need to bring out the mediastinum here. There is, you can say that it is projecting over the mediastinum, but I can see the inner border through it. So it's probably in the lung in front or behind the mediastinum. Does that make sense?
Yes, that makes sense. Thank you.
Yeah. I mean, just to bring clarity into how you describe these things. You know, I was also in the same position as you, wondering what is that structure? Is that in the mediastinum? And then get confused. But if you think clearly, I mean, if it's in the mediastinum, then you won't be able to, you may be able to see its outer margin because that will be outlined by air. You see the margin of a structure in a chest X-ray only if it's outlined by air. You're seeing that margin because it's outlined by the air in the lung. You're not seeing the origin of the aorta here in the heart because there is no air surrounding it. But there is origin of aorta in the heart, isn't it? You cannot deny that that's not there because you're not seeing it.
Yes.
That makes sense.
Yes, it makes sense. Thank you.
Yeah. So this is just a solitary pulmonary nodule. And it can, most common differential being lung cancer, but this is a metastasis. And solitary pulmonary metastasis, these are the differentials. But the literature says that even in patients with known malignancies, an SPN is more likely to be a lung primary. Yeah, okay, I'll go to the next case.
So I've been provided with a frontal chest radiograph of an adult patient. Now here in this chest radiograph, there is a striking abnormality where there is asymmetry within the contours of the ribs within the right lung apex compared to the left. So they're a bit more immediately deviated and flattened. Perhaps there's an element of surgery here or previous trauma. And within there is tenting of the right hemidiaphragm. In addition, I noted that within the right lower zone and within the right lower zone, there are small pulmonary nodules, and within the left lower zone projecting over the left heart border, probably within the retrocardiac region, there is a increased round density as well. So
that's good. Well picked up. Yeah. So these are the review areas. Now the lung, think of the lung behind the heart. Think of the lung behind the dome of diaphragm. So there's lung behind dome of diaphragm, there's lung behind heart, and lesions can arise within that lung, and that's difficult to be picked up. So review areas. So that's a nodule there. And the right chest, as you said, is a bit deformed. It can be previous surgery. It can be previous surgery for cancer on the right side, in which case this can be metastasis. Yeah. Is that okay? Does that make sense? Yeah.
Yes. Thank you.
Good. Excellent. So after this case, we'll take a short break of 5 minutes, and then we'll start with the next candidate.
I've got a frontal chest radiograph of an adult patient, and the most striking abnormality here is that there is a cavitating lesion projecting over the right hilum and mid-zone with peripheral consolidation and an air fluid level. This has ill-defined margins laterally. The left hilum and the right paratracheal stripe are also within normal limits. The heart size is normal and the lungs are otherwise clear. There's no subdiaphragmatic abnormality and there's no bone abnormality either. So I've got a solitary cavitating lung lesion within the right hilum with a wide differential. My first one would be malignancy, primary lung malignancy, such as squamous cell carcinoma. It's less likely to be metastasis because it's solitary. The other differential would be infections such as tuberculosis or other bacterial infections like Klebsiella or Staph aureus. And this could also be secondary to inflammatory causes such as granulomatosis with polyangiitis or rheumatoid lung. And my final differential will also be perhaps secondary to a congenital cyst such as a pneumatoceal or sequestration which is cavitated. So
good. You picked up all the findings and described it very well. So it is a cavitating lesion. We will go into the definition of cavity and then get a clear idea about what a cavity is later. So that's a cavitating lesion. And you did pick up the air fluid level. Really important to be able to identify air fluid levels on a chest X-ray. We'll be going through a lot of air fluid levels later, but this is well picked up. The only suggestion would be, instead of enumerating all the differentials, this is a trick I learned when I was preparing for my 2B exam, is that put the clinical picture in front and elaborate the differential based on your clinical picture. You say that if this patient is immunocompromised and come with features of infection, if this patient is a diabetic or an alcoholic who has got history of previous lung infections, I would consider a lung abscess. If the patient is completely, there are no signs of infection and is presenting with cough and hemoptysis, I would consider a lung primary bronchogenic carcinoma. If this patient has long history of previous inflammation, like Vigeners, which in this case there is no. In chronic pulmonary vasculitis kind of picture, the rest of the lung will be scarred. They get recurrent respiratory infections with cavities, but the rest of the lung is quite clear and pristine in this case. So that's not a picture here. Does that make sense? So instead of enumerating all the differentials, give the examiner the choices of clinical scenarios and fit each diagnosis into different clinical scenario. Does that make sense?
That makes sense. Thank you, Dr. Rahman.
Excellent. So we'll take a short break now, 5 minutes, not longer than that. It's more a break for me than you guys. And then we'll start with the candidate 3. Okay? Okay. Are you guys there? Hello? Can you hear me?
Hello, we're here, Dr. Raymond.
Yeah, sorry. This is actually pertaining to the previous case, lung cavity. So what is a cavity? Cavity is an abnormal thick-walled airspace in the lung. So note all these terminologies. It's an abnormal and it's thick-walled. It's an airspace. It's not a normal airspace. It's not a thin-walled airspace. A thin-walled airspace can be described as a cyst. And it's not an airspace with no wall. An airspace with no wall can be an emphysematous space. So that's just to bring some perspectives into what can be called a cavity. And these are the broad differentials which you know already. Okay, now we will take candidate 3.
Hello.
Hello, hi. This is okay?
Should I start? I'm presented with a frontal radiograph of the chest. There is a right upper zone opacity with peripheral lucency suggestive of an air crescent sign. The appearances elsewhere, I cannot see any further lesions. There is no pleural effusions and no bony destruction. I cannot appreciate any hilar lymphadenopathy. My primary differential for this case with an opacity with an air crescent sign would be an aspergilloma. I wonder whether this patient has a history of a previous TB, and I would look at previous imaging to look for any cavities, because often these can grow in pre-existing cavities.
Yeah,
I would
perfect. Yeah, that's fine.
I would-
Yeah, that's it. You are there. So that's the fungal borer, mycetoma in a cavity. Most commonly, these appear in TB cavities. Yeah, rest of the it can also happen in sarcoid cavities, cystic bronchiectasis cavities, and so on. That's the CT showing the same air crescent sign. Most commonly in TB cavity, can happen in sarcoid cavities, bronchiectasis, bronchogenic cyst, etc. And air crescent is dependent fungal borer in a cavity with a rim of air above. Okay.
I am
Yeah.
a lateral radiograph. In my usual practice, I would review the frontal radiograph first, if that's okay. Or should I carry on? Okay.
That's okay.
Right, okay. So I am presented with a frontal radiograph of the chest. There is a flattening of the left hemidiaphragm, and I can appreciate an opacity in the left retrocardiac region. This is likely within the lungs, as it is mostly well circumscribed posterior to the heart, with slight silhouetting of the descending aorta, suggesting that it might be in the left lower zone, left lower lobe. The flattening of the left hemidiaphragm, I wonder, I cannot, this sometimes is seen if there was a pleural effusion with a pneumothorax, and I would like to look closer at the lung apices just to ensure that there is no pneumothorax. Otherwise, this is most likely secondary to a pleural effusion. Given that there is a solitary pulmonary mass in the left lower zone with possible left pleural effusion, and I cannot appreciate any destructive bone changes or hyaline-lymphadenopathy or any further lesions. I would be suspicious of malignant etiology. I wonder whether this patient is a smoker. I would review their history, and I wonder about the patient's age as well, because other differentials for this, if the history is not fitting with a malignancy, would consider infection. So a CT would help me to differentiate. Right, okay. So I'm presented with a contrast enhanced CT of the chest. There is a well circumscribed opacity, which appears to be communicating with a vessel that leads into the aorta. My primary differential in this case would be a pulmonary sequestration, and I would like to review further sequences to assess what is the venous connection to this opacity, as oftentimes if it is supplied by the pulmonary veins, this would be intralobar sequestration, and if it is supplied from the main, so IVC or systemic veins, then this would be an extralobar sequestration.
That's perfect. That's 100%. So sequestration, you can see the, sorry, how do I go back? Yeah, you can see the systemic arterial supply to that nodule. And in the previous X-ray, it definitely looks better. I mean, bigger. That's probably there was infection, which might have regressed with antibiotics, and now it's only a little nodule. Systemic arterial supply. Think of sequestration. 2/3 in the left lower lobe, 1/3 in the right lower lobe. As you said, intralobar sequestration has got a systemic arterial supply, but communicates with tracheobronchial tree and pulmonary venous drainage, whereas extralobar does not communicate with airway and venous drainage to systemic arterial supply. So another thing was that the patient was a bit young. If you look at the X-ray, there's no calcification of the costal cartilages, so they present in a young age. Okay, sorry, what is this? Okay, yeah.
I'm presented with a lateral radiograph I am assuming that there's no frontal with this one, but in my usual practice, I would review the frontal radiograph. Is that available?
Yeah, no
That's not
frontal.
available, yes. Right, okay. So there is increased opacification over the left lower, projected over the left thoracic vertebrae. I can actually appreciate some air bronchogram through this. However, it appears to be having obtuse margins with the adjacent chest wall. I wonder whether this is a pleural-based lesion. Looking further, there appears to be blunting of the costophrenic angles. I am presented with a CT image with post-contrast CT sequences in lung and mediastinal windows. Looking at the mediastinal windows, there is a mass, hyperdense mass with it appears as if it's spiculated margins, but I suspect that this is drawing the vessels in, and there's associated pleural thickening and a small effusion. I wonder whether this is round pneumonia rather than a mass lesion. I would review previous imaging. I would correlate with the patient's history. And if there is high clinical suspicion, and if this is an elderly patient with a typical history, I would be concerned about an underlying malignancy, but otherwise I would recommend follow-up imaging for this patient.
What history would you seek to confirm that this is actually round atletixis?
The thing is, sometimes I've seen these followed up with PET CT imaging and so on. If they're persistent, if the patient has a history of weight loss, is a smoker, because sometimes you can have an underlying malignancy that's associated with round.
Let's not go down the MDT route.
Yeah.
Just for sticking to the exam purposes, I was trying to get your knowledge about what can cause rounder atletixis. That's why the question was framed: what history would you seek to check that this is rounder atletixis? Obviously, when it goes to MDT, a lot of these cases do get biopsied, even though the history is classical. But that's a different scenario. For the exam purposes, so what history would you seek to make a diagnosis, or at least give rounder atletixis as the top of the differentials?
Perhaps the history of infection. I'm not sure, to be honest, the typical history for round pneumonia.
Okay, that's okay. Rounded atletixis, the diagnosis was spot on. You did really well. You would see crowding of bronchovascular structures from that mass towards the hilum, as you're seeing here. So there is a bit of crowding, there's a bit of volume loss, and the structures, the bronchovascular structures are going towards that mass. Adjacent pleural thickening, which you correctly picked up, there will be volume loss. And the causes are asbestos exposure. But the more common cause that we see in our practice is patients with post-MI or coronary bypass surgery, or pericarditis after MI. This is the most common cause that you see. And you are right. Often, theoretically, although it is quite typical of rounder atletixis, and in the exam setting, you can make a diagnosis of rounder atletixis and leave it there. Although if you want to go to the realm of MDT and whether they'll get PET CT or biopsy, you can. That will give the impression that you have been to a few chest MDTs. Okay, so rounder atletixis, that's good diagnosis. Well done. Next one.
I'm presented with a frontal radiograph of the chest with magnified views of the upper and mid zones. There is a solitary, or actually I can appreciate at least two left upper zone rounded opacities, which are well circumscribed, suspicious for pulmonary nodules. Looking elsewhere, I can appreciate a a further opacity projected at the level of the aortopulmonary window, which is not silhouetting the cardiac border, suggesting that this is either middle mediastinal, more likely than posterior mediastinal. So I suspect that there's a lymph node associated with this. In the right hilum, there is also increased opacification, suspicious for a lymphadenopathy.
I'm sorry, the nodule is in the left upper lobe, correct?
Yes.
So are you referring to this one?
Yes, and there's a second one, possibly just underneath it, medially. Yeah, there is that another there. Yeah.
Yeah. So that's good. That's the findings. Yeah, that's correct. Yeah. So how would you describe those findings then?
So this is well circumscribed. It does not have spiculated margins. However, they're quite proximal to each other. I did mention as well that I did see an opacity over the aortopulmonary window or left hilar region. And I wonder whether there is also left adenopathy.
This one?
Underneath. No, if you look at the AP window, the normal slope of the AP window, it looks as if there's another opacity, but I don't know if that's the...
Okay.
Yeah. It's
So
difficult.
it's, I mean, just to bring some perspectives, if you're saying a lymph node, which is outlined by lung, although there is no opacity in the aortopulmonary window, let's say if there is a lymph node sitting here, where will that lymph node be sitting?
If it was in the aortopulmonary window, so if it's
so a lymph node, a mediastinal lymph node, sitting in between the aortic arch and the pulmonary artery, it won't be outlined by a lung in the inside. All you can see on a chest X-ray, if there is a big lymph node there, would be a widening of the mediastinum. Does that make sense? So you don't need to actually look out for these opacities, although there can be a nodular area here, which you find it, you can say, but then if you're perceiving it as a nodule with margins, all margins well defined, then that's not in the mediastinum, that's actually in the lung. I'm trying to just bring some perspectives into how a mediastinal abnormality will be perceived on a chest X-ray versus a lung abnormality.
Yes.
Although in this case there is nothing there. It's just the aortic arch, the pulmonary, the bay, and so on. There is that nodule, and there is this structure which is going into the hilum. So put those two things together. Does anything comes to your mind?
That's, if this is associated with the nodule, I would consider an ABM as a possible differential.
Exactly. Yeah, that's really good diagnosis. Well done. So that's a nodule, and this looks like a nodule, but if you trace it, it's actually going into the hilum. It's just a big blood vessel, and this blood vessel is also a big. So that's a pulmonary AVM. Okay, that's a CT. You can see a large a nodule and a lot of dilated blood vessels. Well done. So what are pulmonary AVMs? They are just high flow, low resistance fistulous connection between the pulmonary artery and pulmonary vein bypassing the lungs. They can be associated with hereditary hemorrhagic telangiectasia, in which case there will be several of them. And on imaging, they just look like nodules with linear serpiginous structures going towards the hilum, which are just distended blood vessels. Okay, next case.
I am presented with a frontal radiograph of the chest. There is increased reticular and nodular opacities, micronodular opacities, most pronounced in the upper and mid zone, with sparing of the costophrenic recesses in the lung bases. There is also increased bilateral hilar opacification. I suspect that there is increased bilateral hilar lymphadenopathy. In summary, I have bilateral upper and mid zone reticular and nodular opacities with bilateral hilar lymphadenopathy. I cannot appreciate a right peritracheal lymph node. I would, there are horizontal, yes, there's increased bilateral hilar shadowing. There's increased central bilateral perihilar shadowing and increased opacification over the upper and mid zones with horizontally placed interstitial opacities, suspicious for curly B lines. There is no pleural effusions. I can also appreciate of the upper lobe vasculature appearances are most likely secondary to pulmonary edema. Although the cardiac shadows are not enlarged and there's no cardiomegaly, this may not be cardiogenic pulmonary edema, but I would also think about pulmonary edema. However, differentials for interstitial lines, such as curly B lines, can also be malignant, such as lymphangitis carcinomatosis, but it's unlikely in this distribution, especially with the perihilar opacities and the upper lobe diversion. I think this is pulmonary edema. I went into the lymphangitis, which was probably a poor choice.
I mean, it can happen in the exam. You know, your mind is in a race to get to the diagnosis, and then you just race ahead, and then you're there at a really fast pace. But you can always retract. You can always go back what you said, refine it. If the radiograph stays there, most of what you said is correct. You just have to refine it a bit more and bring out some more findings. So how are the hilar? Are the hilar enlarged?
What appears to me is, yes, there is prominence of the bilateral hilar, and there is slightly
big.
They're quite big, and actually if I apply the hilum convergence sign, it looks like the opacity is within the hilum. So I suspect, and actually looking at the AP window, there's slight prominence of the AP window, suggestive of pulmonary hypertension in this case. Because I believe that the pulmonary vessels are, pulmonary branches are very prominent, I would be worried about pulmonary hypertension.
Okay, pulmonary artery is completely fine here. So this is actually bilateral hilar enlargement and bilateral reticulonodular opacities with interlobular septal thickening.
With interlobular
for that?
And nodular shadowing. So could this be just? But it doesn't go typical with any fibrotic link changes.
No.
It doesn't go with HP. I really think this is more pulmonary edema, but it's not, is it? Because there's no.
Can hilar be enlarged in pulmonary edema, in cardiogenic as well as non-cardiogenic?
The hilar they can be prone.
So there is hilar lymphadenopathy here. I don't know why there is a thought block for you. You've been doing so well. So there is bilateral hilar enlargement and there is bilateral.
Oh, sorry. So if in that case, I would think about things like bilateral hilar lymphadenopathy. I would think about lymphoma. I would think about TB. I would think about sarcoid as well, especially with the nodular opacities. This is most likely sarcoid. My first impression was sarcoid.
Yeah, that's fine. I mean, it's more, I would describe the appearance as reticulonodular. There are reticulations and nodules. So bilateral reticulonodular shadowing, hilar enlargement, septal thickening. Differentials are sarcoid, lymphoma, lymphangitis carcinomatosa, and maybe not silicosis. That will have more nodules. Yeah.
Thank you.
So that's the HRCT of the same patient, which shows quite a lot of interstitial thickening. So again, broad differentials, you have to narrow it down. In all those conditions where there is pulmonary fibrosis, including connective tissue disorders, asbestosis, etc., the lung volume will be reduced. In all those conditions with reticulations, with expanded volume, we can think of Langerhans, LCH, TAM, TS, etc. So thickened interlobular septa, which is that case, lymphangitis, lymphoma, pneumoconiosis, sarcoid. The top differentials are lymphangitis, lymphoma, sarcoid, and then all the others. Okay. These are all straight taken from Chapman. Okay, next case.
I am presented with a frontal radiograph of the chest. Immediately looking at the images, I cannot appreciate any obvious abnormality, so I will look at my review areas.
It is really tricky to detect on X-rays. I'll just show you the CT straight.
Okay. So in the so there are consolidative changes in the left lower lobe, and looking at the slices of the mid-thorax, there is also patchy ground glass changes, and I suspect in the periphery there is some tree and bud nodularity. I would review further images to look for lymphadenopathy. I would look for bronchial wall thickening. My primary differential in this case, however, with the findings that I have in front of me, it would be an infectious etiology, most likely.
What are the findings again, please?
So I think there's consolidation in the left lower zone. I can't appreciate anything else. There is some lucencies within that, but I think there's just air bronchial.
That's on one image on the left side. And what about the image on the right side?
So on this image, there is some patchy opacities, and there are, I think that there's
How would you describe those opacities? What is the word that can be used to describe them?
Century lobular opacities, ground glass, ground glass. They could, to me, they look like century lobular ground glass changes. And I think in the peripheries, I'm seeing tree and bud nodularity. I would normally zoom in to just have a closer look. But it looks to me that there is ground glass opacities with no interlobular septal thickening. These are likely century lobular. It doesn't look like century lobular ground glass nodules. It looks more like it's infectious. If there is tree and bud nodularity, because I can't appreciate it very well, I would think about atypical infections.
Can it be just ground glass densities in the alveoli and not in the interstitium?
Can you see? Sorry, please repeat the question.
Can it be just ground glass densities in the alveoli and not in the interstitium? Not in the centrilobular interstitium and not in the interlobular interstitium?
Yes, usually infectious causes can sometimes cause alveolar opacities without the interstitium, although it's unusual, but it's still possible.
Okay, I don't know what concept you have about an alveolar process and interstitial process. A lot of infections, or most of the infections, are in the alveolar spaces. That's what they are called as cinar opacities or alveolar opacities. And they just fill up the alveoli, the pus and inflammatory exudates, and this fill up the alveoli. When there are so much, when there is a lot of pus and exudates, inflammatory exudates in the alveoli, that is what you perceive as a consolidation. So that's actually ground glass opacities in the lung, which is in the alveolar space. Do you want to think of differentials with that information?
Yes, so I would think about infections. Is there tree and bud nodularity? Am I right, or is that not correct? That I'm seeing in the peripheries. I would have to zoom in on it. Does that look like tree and bud?
There is no tree and bud nodules. No.
So in this case, given the distribution, this is mostly so left lower lobe consolidation. There is subpleural sparing. I would think about atypical infections. Viral infections can cause this. COVID pneumonia can also cause this. and I would think about bacterial pneumonia as well, but usually this is associated with atypical infections. Given the distribution, there is subpleural sparing.
Okay, so there is one another finding. There's
Yeah.
ground glass densities here, and there is ground glass nodules, ground glass opacities here, and there is also a bit of
Interlobular septal thickening. Yeah.
secondary pulmonary lobule, interlobular septal thickening. So to put ground glass and septal thickening together,
Yeah, if I put ground glass and septal thickening together, that has its own differential. So I would think about things that are causing interstitial edema and alveolar edema in that case. So that can be in lymphangitis carcinomatosis. If it had a geographic appearance and it was more diffuse, I would think about pulmonary alveolar proteinosis. This can also be associated with certain atypical.
that's good. Although lymphangitis is not really an alveolar process, and I don't think lymphangitis comes under the differential of ground glass opacities. So what is a ground glass opacity? Ground glass opacity is in a hazy increase in lung density. There's an interesting description without obscuring, thank you, without obscuring vessels or the airway. So if you go back, this area, can you see the vasculature in between that opacity?
No, this is consolidation. Yeah.
This is consolidated, but you can see the airway, isn't it? So that's why this can be described as a consolidation. Whereas these opacities, they are faint and you still can see the vessels in between, is it not? So they can be described as ground glass densities. This is a pretty straightforward, simple definition. If you can see the blood vessels and the airway, call it ground glass densities. But if you are not seeing the blood vessels, only the airway, with this abrocogram, call it consolidation. Essentially, the process is very similar. If the alveolar filling process is very extensive, it becomes consolidation. And the differentials, it's non-specific. Any airspace filling infiltrates. So it's more airspace than interstitial, although interstitial infiltrates can also appear as ground glass, as you were describing. Centrilobular, meaning the pulmonary lobule is a small polygonal space. If an abnormality like inflammatory exudates start in the centrilobule and spreads across in the alveoli, it can appear as a ground glass density. And it can be a combined airspace and interstitial infiltrates, of which the most common differential is alveolar proteinosis, and that appearance is crazy paving. We'll show more crazy paving cases later. And collapses and increased capillary blood volume. One thing I've not mentioned the differentials. I will go into, differentials are next. So the differentials are infection like PCP, viral pneumonia, which you said atypical pneumonias, pulmonary edema, pulmonary hemorrhage, interstitial lung diseases, all these interstitial lung diseases. Some of them have more propensity to demonstrate ground glass densities, which I won't go. That's not my topic. I'm just dealing with the basics. And alveolar proteinosis and diffuse adenocarcinoma of the lung, previously called bronchoalveolar carcinoma. So if you find ground glass density on its own, think of a PCP virus. If you find ground glass with fine septal thickening, think of alveolar proteinosis, and mostly ground glass densities, think of diffuse adenocarcinoma, or previously known as bronchoalveolar carcinoma. I think we'll go to the next candidate now.
Thank you.
Thank you. You did really well. Good job. Well done. And we'll finish this session at 12. Are you ready? Next candidate.
Candidate 4, can you unmute yourself?
Unmute candidate 4, then if there are mic issues.
I tried to change the mic. Can you hear me now?
Yeah, the voice is audible, but it's not clear, as if there is a bit of trembling.
Candidate 4, if
The
you
problem.
place yourself from the mic, if you sit a bit further away, it should be fine.
Yeah, that might be a good idea. Sit a bit away from the mic.
Away?
Try that. Let's see.
Okay, I'm presented. I'm presented by
No, you can carry on. So where are you? Where are you in the admins? Can you hear candidate 4, because we're going to record it and play it in our in DKT site. So which means that it is for a future use as well. So ideally should be clear.
Yeah, I think the issue is still present. Maybe if candidate 4 can change the microphone, or alternatively,
Let's go to candidate 5 then, and
yeah.
then we can come back to candidate 4 after he sorts his mic. You can test it during the break time separately. Does that make sense?
That's completely fine.
okay.
Thank you. No, just to save time so that everyone's time is not wasted. Sorry about that. Candidate 4, we'll come back to you. Can you unmute candidate 5 now, please?
Hello, doctor. Can you hear me?
Yeah. Go on, please. This X-ray. This is yours now. Sorry about the delay. You know, we are wasting times of everyone, all the candidates, and all those people who are going to listen to it in the recorded video later on the DKT website. So yeah, go on, please. Candidate 5. Can you take the X-ray?
Yes, doctor. So, frontal chest radiograph in a skeletally mature patient, I am seeing opacification in the left lung field with air bronchogram within. The left hemidiaphragm is elevated. There is obscuration of the heart borders. Otherwise, there is vein-like opacity in the rest of the left lung field as well, with the nuptial sign seen along
What X-ray?
the.
I'm interrupting you.
Yeah, sorry, doctor. Yeah,
X-ray is this, please?
more to the spine, the thoracolumbar spine, I believe.
That's good. Yeah.
Frontal thoracolumbar
I didn't
spine.
hear you
Yeah.
describing that this is a frontal X-ray of the
Yeah.
thoracolumbar spine or
Yes.
thoracic spine. The lumbar is only 2 vertebrae.
Yeah. So,
So in
thoracolumbar.
your exam practice, start by describing what X-ray you are presented with.
Okay.
Yeah, or X-ray or CT, and then describe the findings.
Yes. So, vein-like opacity in the left lung field with lucency along the aortic knuckle in keeping with nuptial sign. Elevation of the left rome of hemidiaphragm as well. There's obscuration of the heart margins seen. Otherwise, the contralateral lung is unremarkable. I don't see. I'm assessing through the visualized bony skeleton. I don't see any obvious abnormalities within. There is a mediastinal shift to the left side. So oral findings of left upper loop collapse in this patient. I would compare with any previous imaging if available. If this is a new finding, then patient would need CT thorax, contrast enhanced CT thorax for further evaluation to exclude a central obstructing bronchogenic tumor, which could be the cause.
It's all good, but I just don't want to be nasty to you.
Okay.
Say the thoracic spine, and you described findings on of the lung.
Okay.
Another modality, no, not a modality, another X-ray that you can do to look at the lungs.
Oh, yeah, such as a chest radiograph.
So, expect in exams that findings, for example, an X-ray of the shoulder may show lung abnormality, or an X-ray of the spine may show lung abnormality, and so on and so forth. So, in your normal practice, you would do a chest X-ray. or you would do an X-ray of a proper X-ray of whatever the abnormality pertains to, isn't it?
Yes, yes.
So in an X-ray of the cervical spine, sometimes you may detect a Pancoast tumor. So the first thing to do in those cases is get a chest X-ray. So
Yep.
keep that in mind. Yeah. Yeah, I mean, that's quite common sense, and that's what you do if you are sitting in reporting a pile of X-rays anyway. Yeah. So that's
Yeah.
the chest X-ray of the same patient.
So there is a redemonstration of the opacification in the left lung field with ipsilateral tracheal shift and mediastinal shift. There is obscuration of the heart margins as well as the left side of left hemidiaphragm. Overall findings of collapse in the left lung, likely arising from the left upper loop, as evidenced by slight elevation of the stomach gas bubble. So a patient would require a contrast-enhanced CT thorax to look for the possible cause. So this is the static image, selected axial image of CT thorax in lung window. I am able to see a lesion, endoluminal lesion within the left main bronchus, causing the left upper loop collapse. This may represent endobronchial carcinoid tumor or metastatic lesion. In my routine practice, I've checked the attenuation as well, the Hounsfield units as well. I don't think it fits much of a mucus plug. It doesn't look fluidy in attenuation.
Sorry, I missed the last bit. Sorry, say it again.
I don't think it looks like a mucus plug. I think it looks more like a lesion, endobronchial lesion.
That's good. Good.
So it could be endobronchial carcinoid or metastasis if patient has had a previous malignancy, known case of a malignancy, or patient has constitutional symptoms. Otherwise, I am also seeing another nodule in the right lung.
Yeah, that.
Okay.
I'll give you did really well. You're nearly there. One thing in the exam, as well as in the real life, is that we should be able to capture all the information that's available in an imaging modality or imaging study. So in an exam, everything is presented. It's presented with a reason.
Yes.
There is a CT measurement in that.
Yes, I'm seeing it now. I'm so sorry. So it is showing.
Make it a practice to actively seek information in an image. Don't just be passive. Actively seek. Oh, what is that in that corner? What is that? Don't say it out. It may be completely irrelevant, so don't say it out. But in your mind, when you're doing the exam, actively seek information. Is there something in the bone? Is there something? But don't say it out. Seek the information that is there, hidden. It's not hidden, it's there. It's just that our eyes are not getting there. That's what this practice is all about. It's about getting your eyes to training your eyes and your brain to seek out that information. So there is the CT density measured in there. And what does that show?
It is showing Hounsfield units of negative 180. So this is more close to fatty attenuation. I'm thinking of a lipomatous lesion, possibly a lipoma, endobronchial lipoma, or pulmonary
endobronchial lipoma. It's a really rare condition.
Yeah.
Good for the patient, but patient presented with cough, and then the patient was X-rayed for the spine, and it was completely incidentally picked up. I think, yeah, it's one of my own cases. Endobronchial lipoma. Okay, good job, well done.
Thank you.
So going back to that initial X-ray, this is really useful. Based on the Chapman, increased density of the hemithorax. Now there is mediastinal shift towards the dense side, which means that it is either collapse, agenesis, or hypoplasia. So this agenesis and hypoplasia, they are extremely rare. You may see it in children. So it's almost always collapsed in the real life and exam setting. So increased density with shift towards same side. Think of collapse. Think of mesothelioma. Lymphangitis, completely different picture. Chapman gives this differential, but that's a completely different picture. And pneumonectomy, I'll show you a case of pneumonectomy, but then the whole chest will be opaque. And the other differentials that you know already. Okay, next case.
Yes. Frontal chest radiograph in a skeletally mature patient. There is a total whiteout of the left lung field. There is obscuration of the heart margins. There is obscuration of the left dome of hemidiaphragm. There is ipsilateral shifting of the trachea to the affected side. Otherwise, I am able to appreciate another opacity, rounded opacity at the right lower zone, medial in location. And I don't see right pleural effusion. I am assessing the bony skeleton now. I am not seeing any rib abnormalities, particularly on the left side of the chest wall. Trying to assess the rest of the bones, I am not seeing any obvious bony skeleton abnormality. So in a patient with total whiteout of the lung, filled with ipsilateral shifting of the trachea, I am thinking of total lung collapse together with the opacity in the right lung. This could be due to a central bronchogenic tumor and with metastasis to the contralateral lung as well. So patient, other different, sorry, doctor?
Yeah, go on, other differentials, please.
Other differential would be a post-pneumonectomy changes, but I don't see any obvious rib defects, particularly at the posterior rib defects in the left side to support that finding. Other than that, mesothelioma and all would not cause so much of would not cause midline, I mean the tracheal shifting. Actually it would be more static and frozen chest. So I think that the patient requires a CT thorax or further evaluation and comparison with any previous image.
Yeah, that's good. So a completely opaque hemithorax. Differentials are either pneumonectomy, in which you will see bronchial clips or some evidence of surgery. If you don't see any evidence of surgery, then the other differential is a total lung collapse. And particularly in this case, there is shift of mediastinum. So a total lung collapse is the most likely differential. And a total lung collapse in an adult grown-up patient is usually caused by a bronchogenic carcinoma causing obstruction to the main bronchus, which is what is in this case. And there is a nodule on the other side, which means that there is metastasis to the contralateral lung. Okay, that's a CT, which shows complete collapse of the left lung. I've just shown you the soft tissue picture, just to bring your attention that the lung mass itself is hypodense and necrotic, whereas that's the collapsed lung, which is uniformly hyper enhancing, and there is a bit of effusion as well.
So I'm provided with frontal chest radiograph in a skeletally mature patient. I am seeing opacification at the right upper to mid zone. It is bounded by the transverse fissure inferiorly, and looking through the opacity, the upper margin is rather straight and horizontal in configuration. Otherwise, I am not seeing any calcifications within. I am assessing the rest of the lung fields now. I don't see any abnormality in the rest of the lung fields, and there assessing the hilum, I don't see any hilar enlargement, and the bony skeleton appears unremarkable as well. Opacification in the right upper to mid zone, bounded by the transverse fissure, and with air fluid level within. So I'm thinking of a infective etiology. Could be like a gas producing organism involved in this process. Probably like Staphylococcus and Klebsiella infection.
Patient is not unwell.
Okay, so this could also represent a cavitating lesion with air fluid level within. If a patient has had a previous pre-existing cavity, so comparison with the previous chest radiograph, if available, would be helpful to see if there was any pre-existing cavity.
So, I mean, if it's a pre-existing cavity, sorry, what was the thought process? I'm not poking at you. Just to get that thought process. What were you thinking? So if there's a cavity, what does that mean? How does that help in your differential?
Yeah, I was thinking, but this is a bit. This doesn't look like air crescent, like a crescentric sign for aspergilloma.
Just that the walls of the cavity are merging with surrounding consolidation. You're not seeing the walls of the cavity. It's a cavity with air fluid level.
Okay.
Isn't it?
But yes, and patient is not acutely unwell.
You can't see any lung here. It's actually empty airspace. Inside a lung, an empty airspace surrounded by wall. And it has got an air fluid level. So it's a cavity with air fluid level. Quite simple.
Okay.
Compared to the previous case I showed you, if the patient is acutely unwell, you would think of a lung abscess. Differential air fluid level. One of them is lung abscess.
Yes.
Now, could this air fluid level be in the pleural space outside the lung? What would you call it?
It could be encysted empyema.
Okay, that's the pathological abnormality that causes the condition. But what is the imaging description for an air fluid level in the pleural space?
Incomplete border sign when we see something suggesting that it is. Okay, all right.
Pneumothorax is air in the pleural space.
Yeah.
Pleural effusion is just fluid in the pleural space, and a hydropneumothorax is air and fluid level. You don't get air in the pleura.
Yeah.
A pleura is just two membranes which have very little fluid normally. When there is fluid which is manifestable, that's called pleural effusion, and you don't get air unless pneumothorax. But if you get air and fluid, that's called hydropneumothorax. So when you see air fluid level within the confines of the chest wall, the most likely differentials are it's in the lung, in which case it's a lung abscess or a necrotic neoplasm and so on and so forth, a cavity with air fluid level, or it's hydropneumothorax. We will go into those differentials of hydropneumothorax later. Just because you were a bit, the thought process was a little bit not clear. That's why I brought up hydropneumothorax here. So this is most likely a cavity with air fluid level.
Okay.
Differentials, I'll give you the CT in this instance. So to navigate that, similar to probably you were not listening or you didn't capture that, to navigate that, you can say that if the patient is acutely unwell, you think of an acute condition, which is a lung abscess. But if the patient is not acutely unwell and long history of TB, then a bleeding into a pre-existing TB cavity, that is what you were saying. You were looking for if there is a pre-existing cavity, then it can be a bleeding into the cavity, and if the patient has hemoptysis and so on. Or it can be if the patient has cough and fresh hemoptysis, you would think of a lung cancer, bronchogenic cancer, which is also a differential for air fluid level, isn't it?
Okay. Yes.
So that's a CT of the same patient.
Okay. So selected images in lung and soft tissue window. There is a cavity seen at the left upper zone with surrounding consolidation. I'm seeing the air at the dependent aspect. Mm,
It's defying gravity, no?
yeah. Okay. It is at the
What is
dependent aspect. So I am thinking if this CT was done Rohun, that has caused the gas.
Yeah. So try to look for CTs in different positions. You know, they may trick you. So the CT, if you look at the gantry, you can see the gantry here.
Yeah.
You see the gantry here. So the patient is prone. The anterior chest wall is on the gantry. So look for gantry all the time. You know, they may trick you prone and supine CTs. I use it in my daily practice even now.
Okay.
Sometimes odd things seen. Oh, why is that like that? And then you look at the gantry, and then you realize, oh, that's a supine, that's a prone CT. You know, that's a prone CT. Not that fluid is defying gravity and staying like in a space up. So that's actually a bronchogenic cancer. And you can see quite thick soft tissue there. Can you see that?
Yes.
Quite thick soft tissue, on which on the background of which it has got probably quite a lot of necrosis, giving the fluid, and it may have developed a fistula to one of the small bronchus or something, which may explain the air in it. So this will be taken before the biopsy, I think. Yeah.
Hello. Yes, we can start.
So is the mic sorted for candidate 4?
Yes, Dr. Rahman.
Yes, I think.
Wonderful. Okay.
Can you hear me now?
Yeah. Go on.
Okay.
That's your case.
Sorry for inconvenience. So I'm presented with frontal radiograph of skeletally mature patient.
Just 1 second. Sorry. Okay, the mic was working before. Are you using your phone again, or are you using the other one?
Using the phone.
Okay, there is that still, which is a bit of a shame.
Dr. Rahman, we can do candidate 4 at the very end
Hello?
after the lunch break.
I'm using the phone now.
Oh no, that there is big disturbance. I'm so sorry. Can we start with candidate 6, please? We'll put up this mic later.
Yes.
Good afternoon, sir. Can you hear me well? Hello, can you hear me well?
That's actually better, yeah. Go now.
That's candidate 6, Dr. Rahman.
Yes, can I start?
Yeah, that's better. Go on.
Okay, thank you, sir. I am presented with plain X-ray PE view of skeletally mature patient. From the first instant, I can see that there is hyperdense opacity seen at projecting at the medial aspect of the left hemisthorax. It's I can see that the descending aorta and aortic knuckle is well delineated. The anterior border of the heart is
Yeah, sorry, I muted by mistake. So you're not candidate 4, you're candidate 6, no?
Yes, I am candidate 6. Can I go?
Yeah, go on.
Okay. The opacity, I can see that the descending aorta and aortic knuckle is well delineated. The anterior aspect of the heart, the border of the heart is well delineated. Also, I can see that the highlight.
How would you describe this finding on the X-ray? What is one word or one or two words or two words that you can use to describe this abnormality?
This is mediastinal lesion seen at the right and also at the left side of the both sides.
You can use this term called mediastinal widening.
Yes.
Yeah. So mediastinal
Yes.
widening on both sides. So again, to bring the whole idea of this course is to share some of my perspectives I learned when I was preparing for this exam. So mediastinum, what is mediastinum? Mediastinum is a space in between the two lungs. So you have this chest. A chest is a bell-shaped structure, space. And on both sides, it's filled with two lungs. And in between the two lungs is a space. It's a space called mediastinum. So that mediastinum contains various structures, mainly the big heart and pericardium, and then blood vessels. The aorta goes, and then the trachea comes in, the esophagus at the back, the spine, and so on. So the way you perceive that mediastinum, because of these structures in a chest X-ray, is as a density which has got several contours and morphology. Because the heart is, because of the shape of the heart at the bottom, it's slightly wide, and then you can see the aortic knuckle, the aortic arch, and so on. That's how we perceive the mediastinum on chest X-ray. So if that soft tissue of the mediastinum, if it has something like a lymph nodal mass, lymphadenopathy, enlargement of the aorta, etc., it will widen. We perceive it as the mediastinum being widened on a chest X-ray. So you can use that term that, okay, there is widening of the mediastinal soft tissue shadow to both sides. That's a simple term, and it's 100% correct. You know, if the widening is on the right side and edges into the trachea, you can call it paratracheal widening and so on. But that's also a bit confusing. So I would keep it simple and correct in the exam all the time. I would just say, oh, there is widening of the mediastinum to both sides. Or if you want to just say there is widening of the mediastinum to the left side. Does that make sense? Does that simplify the descriptive terminology for you?
Yes.
Okay, now that's good. Now we have mediastinal widening.
Mediastinal widening, yes.
What do we do next?
On the basis of X-ray, we should localize the compartment of this mediastinal lesion, and then we can proceed for the CT after reviewing X-rays if with previously done.
Okay, so yeah, that's a fair comment. You should try to locate the position of the abnormality to some degree on an X-ray. That's correct. So in this case, would you want to try and locate a little more based on what are the margins that are ciliated?
Yes, I can see that the right-sided hilum is well visualized. The descending aorta and the paravertebral stripe is well preserved. The anterior aspect of the left border of the heart is seen as the lower edge. However, at the superior aspect, the lesion merges itself with the heart. So this lesion is anterior within the anterior compartment of the mediastinum, and I'd like to review the clinical history and previous X-rays of the patient if were done, and recommend further evaluation with contrast enhanced CD, and recommend discussion with the respiratory entity.
Can I just stop you? I know you are in a flow. I know I don't want to. I'm not saying this in a bad way. When the examiner speaks, listen. Okay.
Yes, sir. Yes, sir.
Stop it. Don't call me sir. Even if you're speaking, when the examiner starts to speak, then that means that he has heard what he wants to hear, and then he is prompting you to go to the next stage. Does that make sense? I know you are in a flow and difficult to stop, but you know this is a situation where listening to examiner is really, really key. And then the moment examiner speaks, stop what you're saying and listen. And you have said everything 100% correct. And you have said that you did for previous X-ray, and I was saying that there is no previous X-ray. So the candidate should listen to that. Okay, there is no previous X-ray, and then I would like to do CT. Yeah.
Yes.
Good, excellent. So I'll give you CT.
Okay. I am presented with contrast enhanced CT of the same patient. From the first instant, I can see that there is anterior mediastinal soft tissue lesion seen extending from the retrosternal region till abutting the anterior aspect of the great vessels of the chest. I can see that there are different components within the lesion, with hypodense components that keep with fat density. In my routine practice, I would like to use my density meter to confirm its density, but by the eyeball, I can see
fat density.
Sorry?
Showed fat density?
Yes, by comparing the density by naked eye, I can see that it's keeping with the same density within the subcutaneous tissue. So this is anterior mediastinal mass with fat density. I can see also a small focus of hyperdensity that can keep with calcification. The constellation of the finding keep with anterior mediastinal teratoma. In my routine practice, I would like to communicate the finding with the referring physician and recommend.
Listen, what's your name? I'm so sorry. Listen to the examiner. You've done 100% diagnosis. There is nothing more to be said. So I'm going to the next case. Okay?
Yes, sir. I'm sorry.
Well, then when I start speaking, when the examiner starts speaking, stop.
Maybe there is a bit lag in the reception of your voice. Maybe because I am flowing in my words, so I can't hear you stopping me. I'm sorry.
Okay, that's okay. Sorry about that. Anyway, that's good. Well done. Good diagnosis. It's a mediastinal teratoma. It's probably arising in the thymus, and it's in the anterior mediastinum. Okay, good job. Well done. So this is the just taken from the Chapman, and this is a really useful slide, not just for the exam, for rest of your lives. So the arbitrarily, again, mediastinum is just the space between the lungs. It's not, nobody has put compartments in between those 1, 2, and 3. It is just arbitrary spaces, or there's no, this is one continuous space. We are dividing, Chapman is dividing it into 3 for the ease of differential diagnosis. And in the upper part of the anterior mediastinum, the most common differentials of a mass lesion are goiter, thymic tumor, lymph nodes, and something from the blood vessel. In the mid part, again, the thymus could extend to a bit below, and thymic tumor, germ cell tumor, which is again arising from the thymus, and sternal tumors. And in the lower part of anterior mediastinum, it's pericardial fat pad, pericardial cyst, Mogagni hernia, and diaphragmatic hump. This is really useful. Posterior mediastinum, again, Chapman differentiates it into paravertebral, anything from the bone like Mets or myeloma, anapsis, extramedullary hematopoiesis, and neurogenic tumor. So anything in adjacent to the spine, and it can be either from the spine or just outside the spine, of which there are only two differentials. If you look carefully, only extramedullary hematopoiesis and neurogenic tumor. So it's quite simple. In the posterior mediastinum adjacent to the spine, either it can be from the spine or it's outside the spine. If it's outside the spine, there are only two differentials, neurogenic tumor or extramedullary hematopoiesis. And in the posterior mediastinum, in front of the spine, in the upper part, it can be esophagus, and the lower part, anything that can be from the, esophagus and aorta. And in the lower part of the posterior mediastinum, there are only hiatus hernia or diaphragmatic hernia. It's quite simple actually, differentiating, giving differentials for abnormalities in the mediastinum is quite simple if you look at it this way. And middle mediastinum is in between the anterior and posterior mediastinum, and the structures are heart, great vessels, and trachea and bronchi, lymph nodes, bronchogenic cancer, bronchogenic cyst or aortic aneurysm. Again, these are just arbitrary divisions to make our differentials easier. It's just one continuous space, and a structure in the middle mediastinum can go into the posterior mediastinum and vice versa. A structure, neurogenic tumor in the posterior mediastinum can go into the anterior mediastinum and so on. Okay, next case.
I am presented with brain X-ray PAVU from skeletally acute patient. From the first instant, I can see that there is right-sided hemisthorax opacification with raised the ipsilateral diaphragm. From the first instant also I can see that there is heterogeneous soft tissue density seen within the opacification. There can be grossly more hyperdense foci towards its upper wall. I cannot detect the right border of the heart. However, I can detect the hilar vessels. I can detect the outlines of the descending aorta and paravertebral lines. So my differential diagnosis here includes either anterior mediastinal lesion or pleural lesion. In my routine practice, I would like to review the history of the patient and with X-rays. I can also recommend.
Sorry, where is the anterior mediastinal lesion again, please?
Sorry?
Where is the anterior mediastinal lesion again?
Yes, I can see the border of the heart on the right side. And I can see the paravertebral stripe and the outlines of the descending aorta is rather preserved. This lesion keeps with the anterior compartment of the mediastinum or maybe pleural.
Okay, I'm just going to stop you there. Admins, is there a way to give the pointer to the candidate? Previously, we used to have it. Pointer or annotation, sharing the annotation. Is that option available?
I'm just going to check for you now.
It's okay. We won't waste a lot of time. I'm not quite sure where the anterior mediastinal mass is. So this is the abnormality. Is that what you are referring to?
What is it?
Is this what you are referring to? The
Yeah. This one. This one.
This whole structure, correct?
Yes.
Okay. Right. Okay. Right. Okay, this is so big and it is outlining the air. Can you see that it's outlining the air, the lung air? It's highly unlikely to be mediastinal in origin. I would not describe this as a mediastinal lesion. This is primarily in the chest. It could be, it's more likely the epicenter. If you look at the contour of the mass, the epicenter of the mass is more likely in the right hemithorax, in the lung, and not in the mediastinum. Okay, so anyway, I'll give you the CT for that.
I am presented with CT scan of the same patient. I can see that there is left-sided. I can see the right hemisthorax is rather clear. I am trying to correspond the detected abnormality with the CT. I can see the heart is well delineated, no obvious mediastinal masses. So I just want to check image 4. Is this thing? This can be a lesion in the left lobe of the lung.
Okay, so soft tissue CT. Soft tissue window, and there is a large mass lesion occupying the entire right hemithorax.
Yes, this can be air-filled, but I want to check the pulmonary window to confirm this.
I don't have it, and it's got a pedicle into the anterior mediastinum. So this is an appearance of a thymolipoma. Okay, the reason why it is thymous is because it has got a pedicle into the anterior mediastinum. Okay, we'll go to the next case now.
Yes, okay.
We will skip this. Oh yeah, no. You go on. Yeah, go on. Go on, yeah.
I am presented with plain X-ray of skeletal immature patient PVU. From the first instant, I can see that there is a mild degree of prominence of the right paratracheal region. I can not see that the trachea itself is shifted from the mediastinal. Yes, this area that you pointed, doctor, and the upper one, slightly upper to it.
We'll stop you there.
Yes.
Is this what you refer?
Yes.
Excellent. That's really good. Yeah, this is a bit of widening of the mediastinum on the right side. That's correct.
Yes.
I don't know. I know what you meant when you said right paratracheal. You meant this, but paratracheal, right paratracheal, I would expect it to be here. This is a bit lower down, isn't it? So again, that was why I was telling you in the first case itself, using a term slightly more generic might be a safer option. There is no harm in describing this as a widening of the mediastinum on the right side. If you call it paratracheal, yes. It's not really paratracheal, isn't it? It's trachea is here, and then that's the tracheal carina. It's more in the more below the paratracheal region. So use a term that is a bit more generic and safe.
Mediastinal widening, yes.
Yeah, a bit more safe. Yeah, that's good. Yeah, so I'll give you CT for that.
I am presented with contrast enhanced CT of the same patient. The striking finding of the abnormality of the study is the demonstration of soft tissue lesion at the anterior mediastinal compartment. I cannot see gross calcification or areas of I can see small areas of different density at the image 4 at the right aspect and slightly at the left aspect. I think it doesn't keep with the density of fat. I would like to measure it by densimeter, and by excluding fat, my differential diagnosis here includes thymoma.
There is no fat density.
Yes. So teratoma is less likely. I would like to trace the lesion upward to exclude its relation with the thyroid. by excluding thyroid lesion and teratoma. The list of differential diagnosis includes thymoma as the first possibility. The other possibility, other differential diagnosis can be lymphoma. It depends on the histopathological correlation to confirm the nature of the neoplastic process.
Yeah. So basically, it's the most common differential. If you go back to the anterior mediastinum, it's somewhere here. That lesion is between 1 and 2. So between 1 and 2, the most common abnormality is a thymic lesion. Yeah. So
Yes.
it is a thymic lesion, which is and most common thymic mass is a thymoma. The only thing that I would have wanted you to mention was that the margins of the lesion are not clearly outlined, well defined here. The margins, the lesion is actually invading the vascular structures. Can you see that it's
Yes.
invading the superior mediastinum, superior vena cava, which means
Yes,
that it's
yes.
an invasive thymoma. Okay,
Yes.
so thymic lesion, invasive thymoma. Okay, next case. Sorry, yeah, just as a repeat of the same thing. Okay, go on, next case.
I am presented with plain X-ray of skeletally mature patient. From the first instant, I can see that there is mediastinal widening, seen more common at the right side. There is a mild degree of displacement of the trachea to the left side. I can see that the hilar vessels is well delineated at both sides. Both cardiac borders are well delineated. This lesion more likely to be, I cannot see that the lesion extending upwards in the pseudomediastinal. The lesion is a bit extending upward to the level of the clavicle. This keeps with positive cervicothoracic sign. And my differential diagnosis here includes posterior mediastinal lesion as my first possibility. Can I proceed?
That's good. Yeah, well done. It is really good. You did pick it up. So you can see the margin going above the upper margin of the clavicle, which means that
Yes.
thoracic sign is positive, which means that it is in the posterior mediastinum. Yeah, so that's really good. I'll give you the CT. You can see a soft tissue mass lesion in the posterior mediastinum adjacent to the trachea and in front of the spine. And so what are the differentials in this case?
Regarding the characteristics, imaging characteristics and the location, neurogenic tumor can be on the top of the differential diagnosis. Other differential diagnosis, yes.
Yeah, so if you look at the posterior mediastinum, if you look here, something that's paraspinal but not in the spine and soft tissue, there are only two differentials: extramedullary hematopoiesis and neurogenic tumor. It's so simple, isn't it? Okay, so that's very good. Well done.
Thank you.
That's the CT and MRI. So this is anterior cervicothoracic sign. The anterior mediastinum stops at the level of the superior margin of clavicle. So therefore, if you can see the lateral margin above the superior margin of clavicle, that means it is located either in the neck or in the posterior mediastinum. It's very unusual for a neck mass to be perceived on a chest X-ray. So it's usually a posterior mediastinal mass. So again, this is something that I have been telling. When you see a margin, that means it is outlined by air. If it is outlined by soft tissue, then you won't see it as a margin on an X-ray. So the reason why you're seeing you're seeing the lateral margin is that because it is sitting behind in the posterior mediastinum, and its lateral margin is outlined by air in the lung, which is what you're perceiving here. Okay, so that's what cervicothoracic sign is. It's a sign of posterior mediastinal abnormality on a chest X-ray. So that's a big mass adjacent to the mediastinum, and you can see that the lateral margin is seen. So it's a posterior mediastinal neurogenic tumor. Okay, so we go to the next candidate now.
Thank you, Dr. so much.
Thank you. Well done.
Hi, Dr. Rahman.
Hello. This case is for you now.
Okay. So I'm presented with a frontal chest radiograph of an adult. The most striking abnormality that I can see is a retrocardiac opacity within the lower thorax. Scrutinizing this a little bit further, I can see that this is separate from the heart, but there is no margin between this opacity and the left paravertebral spine. I'm looking elsewhere for any other masses or any other areas of mediastinal widening, which I cannot see. So in this case, I would say that this is a concerning for a posterior mediastinal mass.
That's good. Yeah, yeah, it is. Yeah. CT of the same patient?
So presented with axial CT slices.
Stop you. You know, in that case, ideally you should ask for a previous radiograph or CT.
Okay.
Yeah, go on. Yeah.
Thank you. So I'm presented with a CT of the same patient with axial slices. I can see a well-defined lesion in the posterior mediastinum adjacent to the left, on the left side, adjacent to the superior to the spine. It seems to be mostly of a soft tissue density with foci of calcification inferiorly. So in summary, this is a calcified posterior mediastinal soft tissue lesion.
Differential?
Differential could be a chondrosarcoma or
not paying attention, not enough coffee in the morning?
sorry, extramedullary hematopoiesis.
Yeah, so you know, if you look at this, a paravertebral lesion, soft tissue density, there are only two differentials.
Mm-hmm.
It's either a neurogenic tumor, it's either an extramedullary hematopoiesis.
Yeah.
It's outside the spine, clearly, that abnormality. It's not in the spine.
Yeah.
And adjacent to the spine, posterior mediastinum, it's quite simple. You know, I find it useful in my daily practice. We come across reporting in a pile of CT, soft tissue lesion. I look for bony changes in extramedullary hematopoiesis. If there are none, neurofibroma, neurogenic tumor, I don't even bother to characterize further the neurogenic ganglioneuroma, blah, blah, blah. That's not my job. It's just a neurogenic tumor and leave it to the thoracic MDT to sort it out, isn't it?
Yes.
Quite simple. Okay. Yeah, so just to highlight that, two differentials, extramedullary hematopoiesis and neurogenic tumor. Okay, next case.
I'm presented with a frontal chest radiograph of an adult. The most striking abnormality is a widening of the upper mediastinum just beneath the clavicle on the left side. I can see the margin of the aortic knuckle separate from the margin of the opacity. So I think this would probably be in keeping with a, just try to see if I can see spine. I can see a margin between the spine and the mass. So I would think that this is a left anterior mediastinal opacity. And I would compare with any previous chest radiographs if available, and if none, I would ask for a CT chest with contrast. I can also see the aortic knuckle is quite enlarged, quite big, and dense. I'm just trying to see if it extends, sorry, the opacity, whether it extends beyond the superior margin of the clavicle. And I don't think it does. So, yeah. In summary, this is a left widening of the left mediastinum, which would be most in keeping with a left anterior mediastinal mass. Is there any relevant history with regards to this patient?
Have you seen rib notching?
Yes, I have. Is there rib notching in this?
So how's the posterior margin, posterior rib on the left side? The 1, 2, 3, fourth rib, left fourth rib.
Okay, sorry, it's not projecting very well, but I think looking at it a bit more closely, I think there probably is a bit of rib, inferior rib notching.
Yeah, so that's scalloping of the, or pressure erosion, not erosion, pressure changes in the inferior margin of the rib. So if you compare that rib, and the all the description about, you know, silhouetting, it's a bit overrated. You can't, it's really tricky to characterize or identify the location of a mediastinal lesion solely by silhouetting, how it silhouettes the aortic sign and so on, aortic knuckle and so on. So if you imagine the arch of aorta, which is what you're seeing projected on an X-ray, a mass still in the mediastinum, but not obscuring its margin, may not silhouette it. So that's not something that's useful. I wouldn't give a lot of importance to it. If it is obscured and if it is quite clear to you and if it is helpful, say it, but it may not be that helpful. And if it's not helpful, don't focus your mind too much on that.
Yeah.
That makes sense. So try to look for minor changes in the rib. And if you look carefully, the lateral margin, actually, you can see that it's a little bit is visible above the upper margin of clavicle. But the description was fine, widening of the mediastinum on the left side, and that description of, you know, a lucency between the spine and the lesion, again, not clear. There is a bit of air, lung air on the top of it, but it's just got obtuse or broad base to the spine and to the mediastinum. You can't see a lung outline between the lesion and the mediastinum at all. So look for subtle rib erosions, rib notching. Okay.
Okay. So this is a frontal chest radiograph of a, I think, of a skeletally immature patient. I can see, again, as with the previous case, there is widening of the superior mediastinum. There is also a lucency projected centrally, just left to the left of the trachea. I can see that this extends into the APCs superiorly. So in this case, I would say that this is most in keeping with probably a thyroid mass or thyroid goiter. And okay, so these are CT axial slices of the same patient, which is showing a low density mass within the posterior mediastinum, which is just trying to figure out where it's coming from. Is it coming from the esophagus? Can't really see the esophagus at this level. I can see an NG tube, I think, posterior to it. So my suspicion is that this is within the esophagus. So my differential for this case would be a esophageal lipoma.
Yeah, or duplication cyst or a bronchogenic cyst in the middle mediastinum. Those are the differentials. Yeah, okay, that's good.
Okay, frontal chest radiograph of an adult patient. So the worst striking abnormality is a retrocardiac opacity to the left of the mediastinum. It appears quite dense. In addition to this, there is a transradiancy of the right lower zone.
Ignore that. That's just projectional.
Okay, fine. So I'm just focusing on this retrocardiac opacity. I would say that you can't see the aortic contour very well. So if this was a history of a patient with coming in with chest pain, I would think about a thoracic aortic aneurysm. Yeah. If that is not the case, then
Is it a young patient or an older patient?
to me, it looks like an older patient, sort of middle-aged.
Can you see any costal cartilages calcified?
No, not really.
Okay.
Okay, so this is a young patient. Okay. So in that case, this would suggest that there might be a posterior mediastinal mass. And
The bones, just focus on the bones now, ignore the lungs.
focus on the bones. Okay. There's dense appearance to the right lower ribs.
And the clavicles?
I'm not sure. Are there some lytic lesions, lucencies within the distal clavicle?
Yeah, that's good.
So,
Are
okay.
they bilateral?
Yes, bilateral. So bilateral lucencies within the distal clavicle.
That is uniform. So is that describable as diaphyseal widening?
Diaphyseal widening. Okay. Okay. So so diaphyseal widening with a posterior mediastinal enlargement. Say, would this be in keeping with extramedullary hematopoiesis?
Yeah, that's correct. Yeah. So the bones are actually endosteum is thin because the marrow is hyperactive. Even the ribs are all a bit wider if you look carefully. If you look at the previous X-ray, sorry, I'll show you another X-ray for comparison. Look at that clavicle. You know, the diaphysis or the marrow is cortex is a lot more thin, thick, and the bones are not, ribs are not that wide. So there's definitely, in comparison, in this case, the ribs are wide, and there is marrow hyperplasia. And with that information, this posterior mediastinal mass, you got it right, extramedullary hematopoiesis. Yeah. Look for these things and try to put these things together.
Yep.
So that's a soft tissue mass adjacent to the spine. And there is only two differentials, extramedullary hematopoiesis or a neurogenic tumor for that. So with the bony changes, it's extramedullary hematopoiesis.
Okay, so I'm presented with a nuclear medicine scan of the thyroid and superior mediastinum. I can see that there's a high uptake within the thyroid, as well as a focus of uptake within the superior central chest. So this would be concerning for a lymphadenopathy within the superior mediastinum.
So obviously you have not seen this. And this is actually a systemic-based subtraction scan.
Okay.
Systemic-based subtraction scan is done for?
Sorry, say that again.
Systemic subtraction scan.
Okay. That's not for carcinoid, is it?
That's for hyperparathyroidism.
Okay.
So what they do is they give systemic, they give technetium as well, and they subtract the technetium image from the systemic image, and that will subtract out the thyroid uptake. So systemic B is taken up by both thyroid and technetium. That is what you're seeing here. That's a parathyroid adenoma, and that's a thyroid gland. But technetium is taken up only by thyroid gland. So when you subtract the systemic B technetium image from systemic B image, you will see only the parathyroid adenoma. And now that's not in the neck; it's in the superior upper mediastinum. So that's an ectopic parathyroid adenoma in the chest.
Wow.
Okay. That's the SPECT CT image showing the ectopic parathyroid adenoma. Okay, next case.
So this is a frontal chest radiograph of an adult. The most striking abnormality is a pneumomediastinum. I can see the outline of the heart as well as extensive.
Very good. Yeah. So that's the air outlining the spine and the heart, pneumomediastinum, on a background of extensive surgical emphysema.
Yeah.
Good job. Well done. Next one.
Okay. This is a chest radiograph of an adult patient. I can see that there is opacity within the left lower zone, which is blunting the left costophrenic angle. There is a little bit of pleural thickening extending superiorly as well.
You can ignore that.
Okay.
I'll explain what they are later.
Okay, fine. Yeah, so a left lower zone opacity.
You can ignore that.
Sorry.
You can ignore that, the left lower zone opacity.
Oh, okay, so ignore the possible pleural effusion. Okay.
Ignore the whatever is happening in the left lower chest.
Okay, so I'll focus my attention to the right hemithorax.
And rest to the X-ray.
And the rest of the X-ray.
Not just the right hemithorax.
Okay. So I can see a right lower zone nodule. It's not very well defined. Here's a little bit speculated.
Ignore that.
Ignore that. Okay. Okay. There's also a cardiac pacemaker in situ.
So the history is that recent cardiac pacemaker insertion.
Recent cardiac pacemaker insertion. Okay, so in that case, I want to look for pneumothorax. I don't think I see any pneumothoraces. I'm looking at the placement of the leads. Just trying to figure out if this is a.
I've
Try-
changed.
Oh, sorry. Sorry, say that again.
I've changed the X-ray. There is not. This is the second X-ray afterwards.
Oh, second extra afterwards. Okay. So now there's blunting of the right costophrenic angle.
Agree
You
with that.
know that, okay. I can see a small lucency within the left apex, and a possible pleural edge, in keeping with a small pneumothorax. I can also see that there is a opacity adjacent to the left aortic knuckle.
It opacity or lucency?
Lucency, sorry. Adjacent to the left aortic knuckle.
Which is?
Sorry, I'm just trying to figure it out.
If there is lucency outlining the mediastinal structures, it is called.
Pneumomediastinum.
Yeah, yes, it's a pneumomediastinum. It's just that it was a bit subtle in the first, and then it was a bit more manifest in the next. So pneumomediastinum is air in the space between the lungs, which we call mediastinum. All these causes secondary and spontaneous. Most commonly, it's after a procedure, either a intubation, central vascular access, endoscopic procedures, or it's or esophageal perforation, or all these conditions, just traumatic blunt injuries and so on.